So help us understand, what does this mean? What is revenue recognition? What is revenue life cycle? Am I even using the right terms?
Yeah, you're really close. So, in the healthcare industry, when we think of revenue leaders or chief revenue officers, vice presidents of revenue cycle, etc., they lead the revenue cycle. So, when you think of a revenue leader in the healthcare space, they're not in business development, they're not looking typically to grow volume in some way or to grow sales, but rather to manage this revenue cycle. And the best way that I can describe it in the most general terms is you think of pre care, care, and post care. And the revenue cycle functions, for the most part, represent scheduling, registration, insurance verification, prior authorization procurement. That's all pre care. Then you have clinical documentation, charge capture, coding. Typically, that occurs at time of service or maybe shortly thereafter. Then you have the back end of the revenue cycle or the tail end of the revenue cycle, and that's when you get into billing, collections, payment posting, denial management. And then even after that, you get to patient billing and collections, write-offs, etc. So there's a continuum to revenue cycle. It's kind of like a production line, I guess, if you want to think of it that way. And it sounds simple enough, but it's not. It's ridiculously complex. And the reason, for the most part, that it is ridiculously complex is our payer systems over time have evolved into layers and layers of non-standard rules that are constantly changing. Okay. And when I refer to payers, I guess just to ground us
Yeah.
in definitions here. So you want to think of payers in three broad categories. So you have your government payers, that's going to be your traditional Medicare and Medicaid. Then you have your commercial payers, which are like our large health insurance companies like United Healthcare, Anthem, Blue Cross Blue Shield, Cigna, Aetna, etc. And then you have self-pay. So that's your third category. And in that self-pay category, you would break it down into three subcategories. So you have pure self-pay, meaning you may be a patient that has no health coverage at all, which is very rare now with the Affordable Care Act, but it is possible. And that's pure self-pay. Then you get into patients who may have coverage, some type of healthcare coverage, but the service that they're seeking isn't covered at the health system or provider they're seeking care. So in those instances, for them to receive care in those institutions, they may have to pay out of pocket and would be considered pure self-pay. And then the third subcategory within the self-pay bucket would be balance after insurance, which is what most patients would fall into. So that means you have some type of health coverage, but that health coverage includes a deductible, a co-insurance, a copay, and your bill won't come until after that healthcare provider has worked through the entire billing and collection cycle with the insurance carrier, which when you're talking about really complex care, that may have included a denial of some kind, there's usually this ping pong match that occurs between a healthcare provider and a payer that could go on, up to a year, which then becomes a patient's dissatisfier, right? Because you're not getting a bill and you receive your services 6 months, 8 months, a year ago. So you want to minimize that as much as possible. But I'm just trying to describe in the most general terms I can think of what the cycle looks like and why it's complex.